A warm good evening to one and all. Welcome to the IDVL Kerala CME Monkeypox. Let's be prepared and update. As we all are aware, new cases of monkeypox are being reported in various districts of Kerala these days. And as dermatologists, we may be the first consultants to see these cases. So it is important to us to know when to suspect a case of monkeypox and also to approach how to approach a case of suspected monkeypox. So today's program is a sensitization for all of us in this regard. And I welcome you all once again to this session. I invite Dr. K. Mohammed, President IDVL Kerala, for the presidential address.
Good evening to all, dear friends, seniors, and students. Welcome you all once more to this program of updating on monkeypox. As you know, human beings are now slaves of certain viruses. The world suffered from COVID-19 pandemic, and we are just coming out of it. Along with the monsoon havoc, the first case of monkeypox reported from our own state. IDVL Kerala, has given a lecture on monkeypox 1 month ago, well ahead of the outbreak, to alarm our members. Now, the IDVL may be the first specialty association to give or to sensitize our members and the medical fraternity as a whole on this subject. Even though monkeypox reported in 1958 in itself in monkeys in Democratic Republic of Congo, and the first human case also was reported in the same country in 1970. Slowly it is spreading to other countries like America and Europe. Now it has come to our state and our country. To enlighten on this, we have Dr. Anuja Elizabeth George, Professor and HOD of Dermatology, Venereology and Leprosy, Government Medical College, Trivandrum, and Dr. Aravind, Professor and HOD of Infectious Diseases of Government Medical College, Thiruvananthapuram, who are the eyewitnesses of this index case. So let us hear from them, and I welcome you to this session once more. And I congratulate Dr. Sandeep Lal for organizing this meeting in short notice, and wishing you all success. Jai Hind, IDVL Jai Hind. Thank you.
Thank you, sir. As we all know, the first case in India was reported and managed in Trivandrum Medical College. So today we have the right persons to enlighten us, Dr. Anuja Elizabeth George and Dr. Aravind sir from Trivandrum Medical College. So we have 2 sessions today, and due to time constraints, we shall take up the question and answers after both the sessions. So the first session is on the clinical manifestations of monkeypox. For the session, I invite Dr. Anuja Elizabeth George, HOD and Professor and HOD, Department of Dermatology, Government Medical College, Trivandrum, a person with vast teaching experience and many research publications in national as well as international journals. And being your student as well, it's my great privilege to welcome you, ma'am, to the session. Over to you, ma'am.
Thank you. Hello and good evening, everyone. It's nice to be back among friends. And thank you, Dr. Mohammed and Dr. Ashwini, for introducing me. Many of you, I'm sure, know that the dreaded monkeypox has unfortunately opened its account in India too, and that the first confirmed case of monkeypox in India is now admitted in Government Medical College, Thiruvananthapuram in Kerala. It is in this context that it was decided to hold a sensitization program for all the dermatologists, because most often the patients who are infected with monkeypox happen to consult the dermatologist first because of the skin and genital lesions of the disease. Therefore, if the dermatologist is able to suspect and diagnose a case of monkeypox, it will be possible to isolate the patient at the first point of contact itself, and we can prevent its spread and avoid it from going to pandemic proportions in our country at least. Everyone here must be aware of the clinical presentations of monkeypox, since IITVL Kerala had already conducted an online program less than a month ago. So I will very briefly walk you through the origin, the etiology, and the clinical manifestations of monkeypox before handing it over to the expert in the field, Dr. Arvind. Shall I start sharing my screen?
Yes, ma'am.
Yes, please.
So with this introduction, I will go to the subject proper. It's about monkeypox in India. So what is monkeypox? It is a viral infection, zoonotic viral infection, because it's transmitted from animals first. The origin of the virus, of the disease. The first description of the disease was in the monkeys in a research facility in 1958. And the first human case of monkeypox was in an infant in Congo. And since then, it has been remaining endemic for a few years in Africa. And there are two variants of the virus, the Central African virus and the West African, of which the West African variant is supposed to be the milder fellow. And in between, there have been small outbreaks in 2003 and 2021. And between 2018 and 2022, there were 9 cases of monkeypox, which was transmitted to the non-endemic countries. And now in 2022 May, we have the current outbreak. It was mainly in Europe. It was seen in the travel associated people and also in some family clusters. And also it was reported mainly from sexual health clinics among homosexuals, bisexuals, and men having sex with men. Now about the etiology, it is an orthopox virus. It belongs to the same family as the variola virus or smallpox virus, which the WHO has declared as eradicated in the year 1980. Now, you may remember that smallpox was a pandemic. The major smallpox pandemic occurred in between 1870 and 1874. Because they both belong to the same family, monkeypox and smallpox have a lot of similarities, and but monkeypox happens to be much milder and is not usually very fatal. And clinically also, there are some differences which we come to later. Because they are belonging to the same family, a person who has been already infected with smallpox or who has been ever vaccinated against smallpox may have some sort of immunity against monkeypox also. But since it was eradicated about 42 years ago, the immunity in the community must have waned. And this could be one of the reasons why monkeypox is now coming up. Now, how does one acquire it? I told you it's a zoonotic infection, so it goes from animals to humans through the scratches or bites of monkeys and rodents. It can go from humans to humans, mainly through the intimate, close skin-to-skin contact with infected body fluids from the vesicles and pustules. So, and it can also go through the mucosal contact. So sexual contact is seen to be more among the homosexuals and bisexuals, as seen in the reports from STI clinics in Europe. And it can also be spread through kissing, cuddling, etc. And aerosol spreading through mucosal of the mucosal respiratory secretions can also lead to spread of the disease. And transplacental transmission of the virus in an infected mother to her fetus can also occur. That is among the human-to-human transmission. Now, it can be transmitted through fomites to humans also by the contaminated beddings and shared towels, etc., from use by an infected person. Now, what about the clinical presentation? The incubation period of the disease is roughly 1 to 2 weeks. It can be a little shorter or it can be a little longer. But generally, during the incubation period, it is not thought to be contagious. And once the incubation period is over, you have the prodrome, characterized by fever, chills, headache, myalgia, and extreme fatigability. And some of them may even have sore throat and cough. And lymphadenopathy is supposed to be very characteristic. The submandibular, cervical, axillary, and inguinal lymph nodes become enlarged. And this is one of the differences between smallpox and monkeypox. You don't get lymphadenopathy in smallpox. Now, after the prodrome, you have an enanthem on the tongue and the oral mucosa, which may not be noticeable. But then comes the skin rash. So about a week after the prodrome of fever, etc., patient develops a skin rash. Usually these skin lesions develop on the face and they spread to the upper and lower limbs. So it's called the centrifugal distribution. And these lesions evolve through 4 stages. You have the macules which occur on the body. They are the flat lesions which then last for about 1 to 2 days, and then it gets converted into the papule, the raised lesion. And 1 to 2 days later, they change into the vesicles. And again, 1 to 2 days later, they change into the pustules. The pustular phase occurs by about the 6th or 7th day of the onset of the rash, that is after the prodrome. And these vesicles and the pustules may become umbilicated in the center, and they develop the characteristic varioliform or the crateриform appearance. And they then change into the erosions or the ulcers, which become crusted. And these scabs fall off soon, which falls off in about a week after the pustules have occurred. And once a scab falls off, the skin re-epithelializes, leaving hyper or hypopigmentation or a puckered scar. So the classical lesions of monkeypox are firm, deep-seated, well-circumscribed, umbilicated lesions. They show some monomorphism. They develop simultaneously and evolve together. So the same size and stage of development on a single site can be seen. The lesions tend to be painful in the beginning, and most often they become itchy towards a subsiding phase. The whole process lasts for about 2 to 4 weeks, and a person is considered infectious from the onset of the enanthem till the scab falls off and re-epithelialization occurs. So I'll show you a few pictures here. In the first picture, you can see a man with a few papules. You can see the marked arrows. In the second picture, you can see the larger papules, some of them showing a little bit of erosions. And in the third one, you can see an umbilicated papule on the forehead with crusting and scab formation. Again, here are other pictures of lesions on the face. Here you see bigger papules and plaques, and some of them even show a central crateриform appearance, that is a depression. And the second set of pictures show that these lesions have almost subsided. They've become flattened out and they are in the subsiding phase. Now the lesions spread to the upper limbs and the lower limbs also. And here you can see the deep-seated vesicles on the palms and also on the forearms. Again, lesions, discrete lesions which are papular, and some of them show the central scab, crusting and scabbing on the limbs. And here is another classical lesion that started as an erythematous macule on the fingertip, turned pustular, then became crusted, and the scab fell off, leaving a small scaly lesion. Again, you can see the crateриform, small papules on the trunk, characteristic lesions on the axilla. Now the mucosal lesions. The patient will also have mucosal lesions, especially the oral cavity, where you may get papules, but most often you see the vesicles or the pustules, which have converted into erosions and ulcers. Similar erosions and ulcers can occur in the cornea and the conjunctiva. And in the genitalia, the patient presents with papules, most of them changing into crateриform lesions, leaving a shallow ulcer-like appearance. So the distribution of the lesion is starting as an enanthem in the tongue and mouth. Present starts as lesions on the face, then centrifugally it spreads to the forearms and legs and the hands and feet, including the palms and soles. So here are a few pictures of the oral cavity. You can see the small erosions on the tongue in the first patient, and the second one you have the well-established ulcer on the sides of the tongue. Now here are the lesions on the genitalia. In the first case, you can see the classical areoliform or crateриform appearance of a papule, which has developed the central umbilication. The top three slides show the characteristic appearance, but in the middle one and the lower one, you can even see the ulcers which have got the polycyclic borders. Some of them have crusted. So they do look like a little bit like the herpetiform ulcers. Again, another set of lesions on the genitalia, classical papules with the varioliform appearance. And the last third slide is that of a female who has developed lesions which have become confluent. In this slide, you can see this is the final stage where the scab is formed and it's about to fall off. And once it falls off, I told you, it will leave hyper or hypopigmentation. And sometimes they may leave a puckered scar. So all in all, you can have lesions of monkeypox from the head to your foot. One interesting thing that is noticed by many people, doctors, especially in the Gulf sector and as per the demographic data from US, is that the females are not as often involved as in males. The reason for this is yet unknown, but the males are many manifold involved than females. And the average age is supposed to be about 36 years. Now, monkeypox can have certain atypical presentations also, and atypical presentations have been noted in this current outbreak also. There may not be any prodromal fever. There may not be any lymphadenopathy. And instead of the onset of a face, the lesions may start on the genitalia or in the perianal areas and may be associated with proctitis. And the lesions which start on the genitalia may not disseminate to, or on the face also, it may not disseminate to other parts of the body. And previously, as described in the classical lesions, where you have monomorphic lesions, pleomorphism of lesions are also now reported. So that means you may see different stages of the lesions in the same person. So as dermatologists, when you see all these lesions, you will have an array of differential diagnosis. You will think of all the infections, especially the sexually transmitted diseases like herpes simplex, syphilis, chancroid, LGV, granuloma inguinale, and chickenpox, disseminated herpes, molluscum contagiosum, and whatnot. And you also have the non-infectious conditions like recurrent after stomatitis when you have lesions in the oral cavity. You may think of Behçet's disease, or it may be traumatic lesions, or it may even mimic squamous cell carcinoma, or it can be drug-induced lesion-like appearance. So that's about the skin lesions. Sometimes the patient may have systemic involvement and complications also. When it involves the respiratory system, it may produce pneumonia. When it affects the CNS, it produces encephalitis. In the eye, the dreaded complication is blindness. Sometimes the patient may have secondary bacterial infections and sepsis, and it can even be fatal. But luckily, fortunately for us, it's rare in the current outbreak because it is thought to be caused by the Western African variant. So now here I'm coming to the first suspected case of monkeypox in India. This was a 35, I'm presenting the case. This is a 35-year-old man who was working in the Gulf country. He developed fever and myalgia. It lasted for about 7 days. By about 7 days, he noticed a few genital lesions. They were small papules, about 6 millimeters size on the shaft of the penis. They eroded and left erosions which were well-defined, non-tender, and not bleeding to touch. Along with this, he had oral lesions also. They were painful crusted papules with surrounding edema, and a few of them were well-defined discrete erosions on the tongue. At about the same time, the patient developed a skin rash also. There were small papules, about 4 millimeters in diameter, and some of them were lesions which looked like vesicles. But when we pricked the lesion, there was no fluid, and we even tried aspirating. There was no fluid from these lesions in the beginning. So these lesions were distributed on the palms of the patient, on the forearms, on his chest, and on his feet also. When the patient was questioned more, he gave a history of protected heterosexual contact 1 week prior to the onset of his fever and lesions. The female partner with whom he had had sexual contact had lesions of eroded lesions on her thighs at the time of the sexual contact. And she also gave a history of fever prior to that, and that she was under investigation for suspected monkeypox. And the same day after the contact, she got a report that she was positive for monkeypox. The patient, our index patient, had also shared plates, spoons, and other utensils with the partner. Our patient was advised by the physicians in the Gulf for investigations for suspected monkeypox, but instead he flew back to Kerala for further management. Now, in Kerala, back in Kerala, he was admitted in Government Medical College, Thiruvananthapuram, under the Department of Infectious Diseases. So confirmation of monkeypox is done by polymerase chain reaction. It can be done on samples of blood, urine, nasopharyngeal swab, and swabs of aspirated fluids from vesicles or pustules, or on the semen. So all these samples have been found to be positive for monkeypox in the reports, previous reports. So in our index case, we sent the samples of blood, urine, nasopharyngeal swab, and swab of the aspirated fluid from a scarified vesicle or the vesicle-like lesion and the papules, as well as the oral lesions. And the report has come out as positive in all these samples. So this turned out to be the first confirmed case of monkeypox in India. So now I would like to hand over the further discussion of this patient and the epidemiological factors and everything from the expert in this field, Dr. Aravind, my good friend. And before I pass on the mic to Dr. Aravind, I would like to thank Dr. Mohammed, the President, Dr. Sandeep Lal, Secretary of IADVL, for conducting the sensitization program and for giving me this opportunity. I would also like to take this opportunity to thank Dr. Shanmugam Pillai, who has shared all these pictures, these beautiful pictures of monkeypox from his own collection, as well as from his friends' collection. Thank you to him also. Thank you, everybody. Thank you for your patient listening. Over to Dr. Ashwini.
Thank you, ma'am. So thank you for that wonderful talk on the clinical manifestations. So I think now we can continue with the epidemiological and management aspects of monkeypox. So I invite Dr. Aravind. Sir is the HOD, Department of Infectious Disease, Government Medical College, Thiruvananthapuram. He is also the infectious disease consultant at Sri Chitra Tirunal Institute and as well as Regional Cancer Center. Sir is the member of State Medical Board, State Expert Committee and State Rapid Response Team for COVID-19. He is also the member of State AEFI Committee and convener of State Vaccination Policy Committee. Over to you, sir.
Good evening. First of all, I would like to thank Mohammed sir and entire IADVL team, especially Anija madam, for giving me this opportunity. Actually, why when the first case of monkeypox was diagnosed in Kerala, the first thought that crossed our mind is the team that is looking after the control of monkeypox in the state is how to engage with the dermatologist, because these two cases, that is the first case that was diagnosed in Trivandrum and the second case in Kannur, that were like sort of classical cases of monkeypox, which are very, very difficult to miss. But as monkeypox, have we missed the atypical manifestations of monkeypox? That we really don't know. Why I'm saying this is both the patients did come from UAE, and even though our patient initially said that no, he had a very contact with a confirmed case of monkeypox, later he changed his statement, and now he's not very sure about that. And the second patient actually does not give history of contact with any person with monkeypox in UAE. That means there are a lot of cases in UAE which are going undiagnosed, and all these patients and some of them might fly back to our state, and we may pick up the classical cases, and sometimes we may end up missing the atypical manifestations. And one thing which is common to both these cases were that they presented to a dermatologist. Second case also, I think that presented to dermatologist, and I would like to thank Dr. Ajay Krishnan. You see here, the dermatologist at the NS hospital, who referred the patient to the Government Medical College Trivandrum with the diagnosis of suspected monkeypox. So the first case also did land up with the dermatologist, just like the second case. So with this, I will go into the presentation proper. So as Madam has clearly discussed about the clinical manifestations, I will just touch upon the epidemiological part, which is of importance to us, and which Madam has not mentioned. So one thing is that the the case which was diagnosed in India also belongs to the West African clade. The good thing about that is, so when we are looking at the pictures in the net and all, we see children with say thousands of deletions, papules and all, that actually belongs to the Central African clade, infection due to Central African clade, and it's not due to West African clade. So the outbreak which is happening centered on Europe and all, is due to the West African clade, and the case which has been diagnosed in Kerala also belongs to the West African clade. So the importance of that is that the mortality is actually very less, and the chance of transmission is also very less compared to the Central African clade. Now, we all know that it is a double-stranded DNA virus belonging to the pox viridae family. And the importance of this is as far as infection prevention control is concerned, because these patients are likely to see the dermatologist first. So it is important that you should take adequate precautions when you're dealing with these patients. So I will suggest a sort of a screening strategy. For example, in our casualty, as of now, we are having only imported cases in Kerala. That means that anyone with an epidemiological link, that is history of travel from any country in the last 21 days, or history of contact with a confirmed or a suspect case of monkeypox, if they are coming to your clinic. So there has to be sort of the screening strategy to ask these questions. And if they say yes to these questions, then probably they should be examined only with the adequate PPE. Adequate PPE does not mean the person protective equipment, entire PPE like thing, the mask, the face shield, the gown, as well as the gloves will do. The certain characteristics of the pox viruses are important. They show extraordinary resistance to drying and increase in temperature, and has very good pH tolerance when compared to other enveloped viruses. So what it means is that there is a possibility of environmental persistence, and that is why the fomites becomes very important. Using the utensils used by the patients, or coming in contact with the clothes or the linen used by the patients, become very important. The good side is that these pox viruses are very sensitive to almost all the common disinfectants that we are using, including soap and water. So hand hygiene. So we should focus more on hand hygiene and 5 moments of hand hygiene. So in our clinics, after examining each patient, we should wash our hands with hand rub or with soap and water. The host, we know the natural reservoir is actually unknown. The humans as well as the monkeys are incidental hosts. The natural reservoir is supposed to be certain rodents, squirrels and all. So as of now, we don't think that the natural reservoir is present in Kerala like that. But still, the people who are on symptom surveillance, or the patients if they're isolated at home. So one advisory is that they should keep away from mammalian pets. So we don't want our mammals to get, or the rodents to get infected from the patients who are isolated. The incubation period already Madam has mentioned. When you're looking at the national guidelines, the period of communicability is actually 1 to 2 days before the onset of rash to until all the scabs are fallen off, and then this reepithelialization occurs. So this is sort of a confusing thing. So 1 to 2 days before the onset of rash. Does that mean that in the pre-symptomatic period also the patient is infectious? It doesn't mean that, because usually the rash occurs around say 2 to 3 days after occurrence of fever. So this just means that the asymptomatic patients are not actually infectious. Once the fever occurs, the patient might become infectious. Now, the problem here is that in Europe and all, the prodromal symptoms are not being reported to that extent now. Usually, the disease is starting with, just the rash. And the subclinical infection as well as the asymptomatic infections are also being reported. For all practical purposes, the patient is likely to be infectious. So just prior to the onset of rash, that is, asymptomatic individuals are not going to be infected. This is with regard to the outbreak which occurred in 2003. That is the first outbreak which occurred outside Africa. That was in USA. Just to highlight the One Health component behind this, the monkeypox outbreak. The giant Gambian rats from the Ghana or Africa was shipped to USA for research. And near the cages of these Gambian rats, the prairie dogs were being kept, and these prairie dogs got infected from these rats. And these prairie dogs were used, used as pets in USA. And from this infected prairie dogs, around 47, the owners of these pets got infected. That was the first outbreak outside Africa. The most important aspect is that none of the patients died during this outbreak. So while in Africa, the mortality of the disease is around 10%, but when it reached USA, there was no mortality. So that is important as far as we are also concerned. So even with the Congo variant or a Central African variant, when the disease occurred in developed nations, the outcome was actually good. So this is the current position. So we have around, say, 12,000 cases, a report from 5 WHO regions, starting from, say, January of this year. We can see that the African region, Eastern Mediterranean, European region, region of Americas, and Western Pacific are affected. And the case which was admitted and diagnosed in Trivandrum Medical College happens to be the first case in Southeast Asia. And the outbreak is mainly concentrated in the European region. So this is actually data till July 4. That is from the WHO bulletin. You can see out of 6,027 cases, the mortality is only 3. So all the 3 deaths occurred in Africa. So means that even though we say that the West African clade, the mortality is say around 1 to 3%, this year, an outbreak when it occurred outside Africa, the mortality is actually very, very, very less. So this is a usual transmission pattern which Madam has discussed. Of importance is that there is a transplacental possibility of infection. So we don't want the pregnant ladies to get infected, because now in pregnancy, the outcomes are not very good. So we have a series of 4 cases from Congo that is not from the West African clade. It is from actually Central African clade. Out of the 4 cases in pregnant women, so one resulted in congenital monkeypox infection and the baby died. The other 2 resulted in miscarriages, and one led to a normal delivery. So 75% of the cases, the outcome was not pretty good. So we don't want our pregnant ladies to get exposed to this virus. The modes of transmission again has been discussed. The clinical features have been discussed. Now coming to one aspect, that's the predictors of progression. The skin manifestations depends on the vaccination status. So vaccination status means that smallpox, the people who have received the smallpox vaccine, that gives around 85% protection against monkeypox also. Also, the manifestation depends on the age, nutrition status, and associated HIV status. The monkeypox used to occur in communities where there is often high background prevalence of malnutrition, parasitic infections, and other significant health compromising conditions. Probably the reason why the case fatality rate when it occurred in Africa used to be very high. The clinical aspects Madam has discussed in detail. So this is actually the time profile of the clinical features. That is now the incubation period, then the febrile stage, the rash stage, followed by recovery. So this is actually the clinical profile from the ECDC WHO website with regard to the distribution of the rash. And also of late, it has been noted that this mainly, the number of the lesions, papules, etc. have come down a lot. And then the lesions are concentrated in the anogenital region. So when you are looking at the demographics, so there is a clustering around the 31 to 40 age group, and around 99% of the affected people are males. It's basically because of, it is being spread in the MSM communities and all. You can see the breakup, the MSM account for around 28.4% of the reported cases and all those things. And one reason why, so we should be engaging with this community as well, and KESAX is doing that. The current clinical presentation is basically atypical, as many cases in newly affected areas are not presenting with the classically described the clinical picture for monkeypox. There is a fever, swollen lymph nodes followed by centrifugal rash is not being described in or being reported in majority of the cases. So this is actually another slide on the case demographics, just to highlight the fact that males are disproportionately increased. Around 99% of the report cases are in males. The demographics from USA also points to this picture. The differential diagnosis Madam has taken us through. And the complications is something that we should be looking for in immunocompromised individuals as well as in pregnant women, etc. And in children less than 8 years. And as described, secondary infection. Our patient actually had secondary periodontitis and was started on antibiotics. And at the time of presentation, patient was having some multiple, as madam described, multiple oral ulcers and along with follicular tonsillitis, and patient had difficulty in swallowing. That was his main symptom. The odonophagia was there. And pneumonia, sepsis, and encephalitis, etc. are described, especially in children less than 8 years and immunocompromised. And the corneal involvement can lead to loss of vision. And one question: our patient had congenital congestion, but which developed later on, but the corneal involvement is actually not there. Now, the most important aspect is we should be aware of the case definition, because many funny things are happening. So one person in a nearby state has been put in a negative pressure ICU because of recent travel to Trivandrum. Around say 2 weeks back, in a neighboring state, they take as travel to Trivandrum as sort of a risk factor for developing monkeypox. And that patient was actually having HFMD, which was proved through the PCR, because the hand, foot, etc. They thought that it is likely to be monkeypox because of epidemiological link of travel to Trivandrum. All sorts of funny things are happening, and the PCR came as positive for enterovirus. So we should be aware of this case definition. Person of any age having history of travel to affected countries within the last 21 days, presenting with an unexplained acute rash, and one or more of the following signs or symptoms, that is lymphadenopathy, fever, headache, body aches, profound weakness, is taken as a suspected case. If this case is actually having gives a history of contact with a proven or a proven case, and if there is an epidemiological link like face-to-face exposure, healthcare workers without adequate PPE, the skin-to-skin contact, and all those things, or sharing of utensils or and clothing, etc., then the person becomes a suspected case. And confirmed case is when the PCR or sequencing become positive for monkeypox. Now, another important aspect is the risk factors and clinical findings described as being associated with severe disease and poor outcomes. So certain patient groups are at risk of development of severe disease, like children, pregnant women, immunocompromised, etc. And also, interestingly, they describe chronic skin conditions like atopic dermatitis and acute skin conditions like burns as at risk of development of complications due to secondary bacterial infections. And certain clinical signs also portend bad prognosis, like nausea, vomiting, painful cervical lymphadenopathy causing dysphagia, poor oral intake, eye pain, vision abnormalities, hepatomegaly, sepsis, dehydration, ARDS, and confusion. And all these actually, the data is derived from the manifestations observed in infection due to the Central African clade and not due to the West African clade. And lab abnormalities, hypoalemia, and transaminitis are also associated with a bad prognosis. Our patient at the time of presentation had transaminitis. Also, his LDH levels were actually very much elevated. Now it is normal. And the D-dimer was also elevated. So probably, that he was in the stage of an inflammatory response or something like that. Now everything has normalized. And based on the number of lesions, there is a severity scoring which has been taken off from the smallpox era. There is mild is less than 25 skin lesions, moderate 25 to 99 skin lesions, severe 100 to 250 skin lesions, and very severe more than 250 skin lesions. And during the West African, the infection due to West African clade, usually the number of skin lesions are actually very, very less. How will you diagnose this? How will you diagnose a patient as having monkeypox? So the most important thing is someone is coming to your clinic, because yesterday's SOP came out. It clearly shows that if someone with a history of travel from an endemic area and it was presented to you within 21 days of arrival in Kerala, is coming to you with a rash, fever, etc., then what are we supposed to do? The SOP says that if your hospital is having an isolation facility, so what do you mean by an isolation facility for monkeypox? If you look at the national guidelines, so monkeypox, since it is not airborne, you just require a room with a separate ventilation. You're supposed to isolate the patient in your own hospital. Okay, so maybe even if it is a Taluk hospital, you are supposed to isolate there, and then you are supposed to inform the DSO. And DSO is supposed to guide you in the sample collection, etc. So the samples that are supposed to be sent has to be sent as per the NIV protocol. So in the national guidelines, which has been adopted by the state with certain modifications, all these the guidelines how to take the sample, etc. are there. So you need to take the 5 ml of blood, 5 ml of urine, then oropharyngeal swab, the throat swab, and then the maximum skin lesions have to be swabbed, deroofed, and all those things. the more the lesions you swab, the yield is likely to be higher. So when you look at the sensitivity of virus from these different samples, the maximum yield is actually for the skin swab, which is around say 46%. So if you are swabbing multiple sites, the chance of picking up the virus is higher. In our case, actually, the repeat sample also was positive for all these samples, including the urine sample. So what they do in NIV Pune, so previously, till now we are sending the samples to NIV Pune, but as of now, NIV Alappuzha is also ready to do the run the PCR, and the VRDS in Trivandrum, Thrissur, as well as Calicut, I believe has received the primers, and when they get approval from ICMR, they will also start running the PCR. So what is being done is initially they will do a generic PCR looking at orthopox virus gene, the DNA, and then if it is positive, they will run the specific the PCR for monkeypox. And if it is also positive, they take it for sequencing to see whether it is West African clade or say Central African clade. And the importance of sending a semen sample, which we have not sent in our patient, is that how long the patient has to abstain from sexual activity. So the guidelines from Europe says that no, you need to, even after the recovery, full recovery, you need to use barrier methods for around 2 months or so. Because there is the series from Italy saying that the virus has been isolated in semen, the viral DNA has been isolated in semen. But WHO has said that even if the viral DNA has been isolated from semen, does not mean sexual transmission. So even though it is spreading in the MSM communities, it's because of very close skin-to-skin contact rather than sexual route of transmission. So in our patient also, we are planning to send the semen sample to see whether the DNA can be isolated from the semen sample of this patient. So coming to the treatment aspect, we know as of now in India, we don't have a specific antiviral drug. We don't also have the vaccine. So as of now, the most important aspect is identifying the patient and isolating the patient to prevent spread to others. So when you look at the spread, the secondary attack rate of this monkeypox, even in household contact, is only 8% when compared to smallpox, where the secondary attack rate was around say 25 to 45%. And in chickenpox, the secondary attack rate. So definitely around say it's very high. So compared to that, the chance of transmission of monkeypox even to very close contacts, household contact, is really less. It is only around 8%. So we need to isolate the patient, and then we need to look at the protection of the compromised skin and mucous membrane, rehydration therapy, symptom alleviation, etc. So in our patient, the basic issue was odynophagia had to be started on NSAIDs, and then IV fluid has to be started because so he cannot take anything. It is very difficult for him to swallow oral food and all solid food. And then the antibiotics had to be started because of suspected periodontitis and all those stuff. Patient isolation, the isolation of the patient should be in an isolation room of the hospital or at home in a separate room with separate ventilation. Patient has to wear a triple layer mask or an N95 mask, and the skin lesion should be covered to the best extent possible using long sleeves and all to minimize the risk of contact to others. Isolation to be continued until all lesions are resolved and scabs have completely fallen off. Now coming to the specific treatment, in US, FDA has not approved, but it's available there. And the European Medical Agency has approved the antiviral drug, the tecovirimat. So tecovirimat actually, is a VP37, that is a protein which is very important for the unwrapping of the viral envelope. So it cannot spread from cell to cell. So tecovirimat is being used for treatment of monkeypox in USA as well as in Europe. And the dosage is actually just like linezolid, is around 600 BD. Other options are brincidofovir and the vaccinia immunoglobulin. So we don't have access to any of this. And coming to the vaccine, they have two vaccines. These are second and third generation smallpox vaccines. As you have already discussed, the smallpox vaccine gives around 85% protection against monkeypox as well. So these vaccines are being used for pre-exposure prophylaxis to people who are working in the lab with monkeypox virus, and also as post-exposure prophylaxis to the risk groups who are likely to develop severe disease. And in MSM communities and all, they are using it also as a ring vaccination strategy to control the spread of the disease. Now, coming to the history of tecovirimat is very interesting because it was approved by US FDA in July 2018, actually for human smallpox. Why should they approve some drug for a disease which has been eradicated in 1980? Because they thought that there is a possibility of bioterrorism due to smallpox. That was why they approved this drug in 2018, and now this drug is being used for monkeypox. When compared to brincidofovir, the viral clearance is actually very fast with tecovirimat, and the chance of complications are also less with tecovirimat compared with brincidofovir. This Jynneos is a live virus vaccine produced from the strain of modified vaccinia virus. And also these two vaccines are available in USA. And will they treat all patients with tecovirimat? Actually, no. They select patients with severe disease, like those with hemorrhagic manifestations, confluent lesions, sepsis, encephalitis, or other conditions requiring hospitalization. When you're looking at the data from Europe, so around 10% of the patients are requiring hospitalization, but ICU is required only for 0.4% of the patients. Patients who may be at higher risk of severe disease happen to be those with immunocompromising conditions, pediatric population, pregnant breastfeeding ladies, and people with atopic dermatitis, burns, etc. The most important aspect is actually the infection prevention and control aspect. So it is not about airborne precautions. It is spread through large respiratory droplets. So the mask, and this, even the triple layer mask may be enough, but majority of us are using N95 mask, and that is good enough. And we need to take care of our conjunctiva as well. So definitely the goggles or the goggles are required. And then the onus has to be on the 5 moments of hand hygiene, respiratory hygiene, cough etiquette, and all those things. And while in hospital, the proper handling of the laundry and linen, very important. Environmental cleaning and disinfection is also very important. And for reusable equipments, decontamination, reprocessing, very important. So what do you mean by the PPE for and taking care of a patient with monkeypox? It is coveralls or gowns, N95 mask, face shield, and double pair of gloves. Now coming to the surveillance strategy, most important aspect is, so whenever you are having someone with an epidemiological link with some lesions, okay, need not be the classical lesion, some lesion entirely like that, we need to isolate the cases, provide optimal care, identify and manage the contacts. Should the contacts be sent for quarantine? The answer is actually no. The contacts are put on the symptom surveillance for 21 days. If they develop any symptom during this time period, they are isolated. Okay, so our strategy is going to be, because majority of the patient, the contacts are also coming from abroad. So the chance of them developing COVID-19 is actually far higher than that of monkeypox. So during the period of symptom surveillance, that is 21 days from the day of contact, what we do is, if they develop fever, so we will test for COVID-19 and then isolate them. Okay, and isolate for 5 days. When fever develops, actually the rash is supposed to appear within 5 days. Once the rash appears, we will send for monkeypox PCR. So the contact tracing, the definition of a contact is a person who has had a face-to-face exposure or a direct physical contact, including sexual contact, with a proven or a suspected case of monkeypox, or contact with contaminated materials such as clothing or bedding. So regarding contact monitoring, we have already discussed about that. And these asymptomatic contacts are also not supposed to donate blood, cells, tissue, organs, or semen while they are under surveillance. So there is no need for quarantine, but the patients has to be under surveillance. And regarding the healthcare workers who have unprotected exposure to patients with monkeypox or possibly contaminated materials, they need not be excluded from work if they are asymptomatic, but they should be undergo active surveillance for 21 days. So I'll end with another, this is not from our case, a 15-year-old man with a history of recent international travel, processed with fever, headache, cough, and rash. Now, all of you know that this is a pleomorphic rash. So it is actually varicella zoster. Should you send for monkeypox PCR? Because here the diagnosis is obvious. But since the patient is having epidemiological link, even if the diagnosis is varicella zoster, as per the WHO guidelines, we are supposed to send for monkeypox PCR also, because co-infections have been documented. So during the period of surveillance, so any patient with epidemiological link during the period of surveillance, 21 days, if they develop rash, and even if you're having an alternate diagnosis for the rash, as per WHO guidance, we are supposed to send for monkeypox PCR also, because of the chance of co-infection. And so this we have already discussed, and I will end with this slide. This picture is not from the West African clade of this is what is being portrayed in the media, newspapers, etc. This is not from the West African clade. This is actually from the Central African clade. So West African clade won't be having this much of lesions. So with this, I will like to end here. Again, like to thank IADVL for this opportunity. Thank you very much.
Thank you, sir, for that enlightening talk. So now we can have a question and answer session. You can. Hello.
Dr. Arvind, thank you. And Dr. Anjita, thank you so much. Very informative talk of the disease we are seeing and actually experienced for the first time. Okay. Dr. Arvind, you said that IND is one US and pseudophore is available in India. Pseudophore.
Sir, actually, the pseudophore has to be imported in India. And there is a actually head-to-head trial between tecovirimat and brincidofovir, where tecovirimat actually was far superior to the brincidofovir.
Okay, why I'm asking this because in case of HIV, got extensive molluscum contagious, it can cause by the pox, but it's supposed to be effective pseudophore. That's why I asked you.
Actually, I have used pseudophore for the patients with CME who have been resistant to valganciclovir. Had to be imported, and it's actually a very costly drug, sir.
Okay.
Hello. Hello, good evening, everyone. Let me first congratulate Dr. Mohammed and IADVL for arranging this sensitization bank. And thank you, Anuja Madam and Dr. Arvind, for that very informative talk. There is a lot of things to learn for us. And as Dr. Arvind said, it's very important for dermatologists because in both these cases, the patients first came to dermatologists. The second case that came to Kerala and admitted in GMC, Government Medical College, Kannur, was also first seen by dermatologist. And thanks to him that we identified it. And this patient also is a returnee from Dubai. He is a school bus driver who was during COVID time in India, but went back to Dubai in February. And he came with this history of 2 days high fever, followed by genital lesion, oral lesion, the skin rash. And presently is in the ward and is recovering well. He is about 25 to 30 pustules, including the genital and oral lesions, and is stable and no fresh lesions are appearing. There are a lot of information that Dr. Arvind shared with us, which are very important for us. Thank you. And our patient, incidentally, gives history of high-risk behavior, but the last high-risk behavior was more than 2 years back, and he also was not able to recollect any contact with a known case of monkeypox, and all his investigations, including VDRL, HIV, hepatitis B, C, are all negative. So this is the information from GMC Kannur. Thank you, Dr. Mohammed.
Thank you, sir and madam. We have a few questions in the chat box. So the first question by Dr. K. Mohammed, is the index case recovered completely without any sequelae? Madam and sir.
Index case, did he recover without any sequelae? That's the question, right?
Is the index case recovered completely without any sequelae?
I think madam will answer because now it's more of dermatological now.
Okay, sir.
When I saw the patient last, he is much better than his initial phase. The oral lesions, most of the oral lesions have healed except a few lesions on the lips. And the lesions on the genitalia have started crusting. And those on the hands and on the chest also have started crusting. So dermatology-wise, he is much better. He's healed, almost healing well. But regarding the question from Mohammed sir about whether there is any sequelae, I think it's a little too early to say. Probably because we have to wait for about 2 to 4 weeks, which is the total duration of the disease, which is at that time we will know whether he leaves any scarring on the body. And the systemic complications, As of now, I don't think there is any because we are not dealing with Dr. Aravind would be the better person to say talk on that.
Systemic complications, as of now, he is not having any system. Mainly, we are giving psychosocial support to him. He's depressed, he's anxious, he's angry to an extent because of what media is saying about him. So this aspect is what I am taking care of. The dermatologic aspect is what Madam is taking care of, because otherwise he's not having much of a systemic problem now. The end organ damage is not there. The transaminitis has resolved. The inflammatory markers have come down a lot. So because at the time of presentation, CRP, ESR, D-dimer, etc., all were very much elevated. Just like, the inflammatory surge in COVID-like scenario. But now all the markers are normal, return to normal.
Okay, sir. Thank you. Another question by Dr. Jenny. Which are the countries maximum affected?
Maximum affected is majority of the cases are clustered in Europe. In Europe, when Spain is having more than 2,000 cases, where Madrid has reported more than 1,000 cases. A city has reported more than 1,000 cases in Spain. The second is Germany with around 1,700 cases. Then Portugal, France, all these countries are having cases. It's clustered around in Europe.
Okay, sir. Okay.
USA has more than 1,500 cases now. And others are not having it. Means countries with very good surveillance system are having more cases. And in the state with the best surveillance system picked up the cases. That's all.
Exactly. Okay, sir. Thank you. Another question by Dr. Anup. Any role for acyclovir?
Actually, no. Acyclovir is chickenpox. Now this is alpha herpes. This belongs to the orthopox virus, and acyclovir is not effective for monkeypox.
Okay. Next question by Dr. Raji. Are the lesions symptomatic? Are the lip lesions common?
Lip lesions, oral lesions are described, and in fact, they say that the lesions, the enanthem is in the oral cavity, the tongue and the buccal mucosa. But as per the reports and the pictures that we see in the reports, especially of CDC, etc., the lip lesions are not that severe. But unlike that, our patient had very severe lesions on his mouth, on the lips, and on the tongue. So that was a little bit different from the so far reported cases. And they were painful also, but the genital lesions were not painful. The oral cavity lesions were quite painful.
At the time of presentation, he had lip edema also, because
yes.
Lip edema, and on looking at his the face, with this much of oral ulcers, we had difficulty in opening the mouth, cannot swallow anything with lip edema. The closest differential would have been drug hypersensitivity, like that. That's what I thought initially, because he said that he took some medicine and from next day onwards he's having that. All other close readers we could have ruled out just by looking at his lip, because lip was edematous and all. Okay, but it is, as Madam has said, it's not that much reported in literature. And then ENT people, when they examine, show follicular tonsillitis, which is also not that much reported, but there are certain case reports from Germany reporting follicular tonsillitis, and studies in animal models, that is in monkeys and all, have shown necrotic lesions in tonsil. Okay. We can say that his oral cavity was disproportionately affected in this case.
Okay, sir. Another question by Dr. Sunita Thomas. Are the lesions in monkeypox itchy or non-itchy? Are they pruritic?
They're actually very much pruritic lesions, very much pruritic. Usually during the stage of crusting and all, they will be very pruritic and supposed to be very painful. But our patient, except from the oral lesions, I don't think in the other lesions he did not complain of that much of pain, and complained of some pruritus, but then it was not a major symptom, because when we go through literature, it's very pruritic lesion. In our case, it was not that much pruritic, but he did complain of itching.
Okay, sir. So that there are two questions.
The basic issue is that whatever literature we are going through is from the Central African plague. That's the problem.
Okay, so thank you. There are two questions on the protective measures. One is, when we see suspected patients with N95 in the OPD, are we considered as contact, by Dr. Manju? Another
Actually,
question.
WHO last month has come with a revised risk stratification, high risk, medium, and low risk. So even doctors who are using full PP and examining the patient. For example, myself and Anija madam, I don't know whether madam is knowing, she is also a low risk contact as per WHO is concerned. And for 21 days, we are supposed to be on surveillance. That is only symptom surveillance. Okay. But suppose you are in the OPD and you are having only N95 mask and say face shield and you are not using a gown, then your risk will go to medium. Why medium means when you are not using a gown, there is a possibility that your body might come in contact with the patient's clothes. Okay. And the patient's cloth is supposed to be infectious. Then you become medium risk. Medium risk means along with the symptom surveillance for 21 days, you will have to monitor your temperature twice daily. So that is what is meant by medium risk. So that I think I will answer that question, right?
Yes. And adding to that, what are the measures to be taken at private clinics by doctors?
So that I think I have already mentioned. So we need to go for face protection with N95 mask and face shield. And then our it's better to wear full sleeves and all. Okay. Because now the dermatologists are going to be the first stop station. If you are not wearing full sleeves, you can use the ideally you should be using the gown. Then the gloves has to be there. And if you are not using that, ensure that you are practicing 5 moments of hand hygiene. I will believe that 5 moments of hand hygiene is going to be much better than gloves because we don't know. You're seeing so much of patients, right? So we cannot use gloves for each and every patient. May be difficult to write and all. So the 5 moments of hand hygiene is very, very important. Soap and water will kill the virus. All the disinfectants, including chloroxidine, will kill the virus. Okay.
Okay, sir. A question by Dr. Shaiju. What is the dose of Cidofovir?
Cidofovir, actually, the dose is 5 milligram per kilogram. It's IV. Okay. And it has to be given weekly once, Cidofovir. But the recent studies are with Brincidofovir. Brincidofovir is actually a container of Cidofovir which can be given orally. Its dose is 200 milligram.
There are a few more questions by Dr. Vibha. What is the treatment protocol being followed in GMC Trivandrum and Kannur currently? I think
It's basically symptomatic treatment. Symptomatic treatment, I will suggest that we get the psychiatric consultation right from day one. This is more, the dermatology part, the ENT part, etc. we can take care of. But then the psychosocial support is very much important for all these patients because they are flying from another country means already they have violated the international health regulations. So there is sort of a witch hunting going on and all these patients are so depressed. So we need to start on psychiatric consultation right from day one.
Okay, sir. What are the investigations done in these cases apart from confirmative investigations by Dr. Surekha?
Actually, we ran the entire lab test. We are trying to find what is happening, right? So the hemogram, the LFT, RFT, along with that, we send the inflammatory markers also. And then, now it is likely to be the sexual route, right? Means, majority of them are having high risk. It's not sexual route. They're having high risk behavior. So we send VDRL, HBsAg, HCV, this TPHA, HSV, etc. In our patient, HSV 1 and 2 were positive. IgM, it was around 2.4 and IgG was very much elevated. And it gives history of around the lesions in the shaft of penis around 1.5 years back also.
Okay, sir. A question by Dr. Sri Kumar. Once infected.
And I forgot to mention one thing, the routine urine. So for this patient, the routine urine showed 25 pastels. Interstitial nephritis also can occur with monkeypox infection.
Okay, sir. Once infected, when is the patient declared completely recovered, even after clinical recovery, to mingle with the normal population? Any lab parameters to decide on this? Actually,
I will answer this question another way. The thing is, we are sending the PCR from all these samples every 4 days. We are repeating the PCR. Okay, but the guideline is that you cannot use PCR to say that one person is non-infective, just like in the case of SARS-CoV-2 infection, because shedding can go on and on and on. Okay, we don't know whether it is due to a viable virus or not. That is why we are looking at the clinical aspect. The scab has to fall off and reepithelialization has to occur. Then we can say that the patient is non-infectious. If you are going by the PCR criteria, it may be very difficult to discharge the patient from the Europe experience.
Okay, sir. A question by Dr. Neetu. Could you please explain once again the protocol to be followed if a private practitioner suspects a case of monkeypox?
if a private practitioner suspects a case of monkeypox, the first thing he has to do is actually isolate the patient. Isolate the patient, ensure that the vitals are stable, and then call up the DSO, district surveillance officer. So then the DSO will actually guide you. Suppose your hospital is not having an isolation facility, majority of the hospitals will have, because we don't require any negative pressure room or any airborne precautions. We just require a separate room with a separate ventilation. So if your hospital is equipped with that, then you can manage the patient in your own hospital. From in a private clinic, the indication for referral has to be if the patient requests referral to a government setup, you can do that. That is indication for referral. Now, how to take the samples and all? You can contact the DSO and you can follow the NIV protocol, which is there in the national guidelines as well as the state guidelines. You can follow that. How to transport the specimens? So that has to be in communication with the district surveillance officer. It is the responsibility of the DSO to transport the samples to the nearest approved lab, because till yesterday it was NIV Pune, but from today it could be NIV Alappuzha. From tomorrow onwards it could be any of the VRDLs. So that all these things will be directed by the district surveillance officer. So what you are supposed to do? Isolate the patient and call up the DSO.
What is the treatment given for oral lesions by Dr. Harish?
In our case, actually, the treatment given for oral lesions were betadine, gargle, all those things for the sore throat aspect. And patient was actually on acyclovir because he had been started on acyclovir from outside, and we stopped it only when the monkeypox was proven. And since HSV was also positive, we ensured that he had received around say 5 to 7 days of acyclovir. That is actually then NSAIDs also, because the pain was very much high. So the patient was on NSAIDs for around say a couple of days.
Okay, sir. Another question by Dr. K.S. Prasanna: how to differentiate genital lesions from genital herpes?
Madam?
Very difficult to differentiate.
Interestingly, in this patient, there's a painless lesion on the penis.
Yes. In this particular case, we could say because these lesions were painless and there was no polymorphism of the lesions. The erosions were not polymorphic. Most of them were discrete lesions and painless. But we have seen pictures where the lesions have become confluent and having polycyclic borders. In such cases, especially if it is painful, it's very difficult to differentiate. At that point, then you will have to rely on the HSV titers also, which might be helpful, especially if you have the IgM titer high.
Okay, madam. I would like to add on my own doubt also to this question. How will you differentiate, ma'am, from HFMD? Any tips? Hello.
Aravind, I think you should be answering that.
How to differentiate from HFMD? Okay. The one thing is actually the evolution of the lesions. The evolution of the lesions in monkeypox is actually not as fast in say varicella zoster measles or HFMD. So evolutions take some time. It is up to say 2 weeks now. Our patient was symptomatic from the 5th of this month, and now it is 20th. So evolution is a slightly slower one. And the second aspect is with regard to the regard to the lymphadenopathy aspect. So the lymphadenopathy in monkeypox is supposed to be sort of generalized lymphadenopathy. You are getting the cervical, inguinal, all those things. In HFMD, the lymph nodes may be there, but they are likely to be very small nodes. And then in HFMD, these are actually the basic differences between the presence of lymphadenopathy and the slow evolution of the lesions. The ones which should be helping us to differentiate HFMD from monkeypox. And then the classical lesions in the source like that, the red point-like thing that we are seeing in this HFMD, I don't think that much will be there in the monkeypox cases. So because in the case from the neighboring state, we could diagnose it as HFMD. There was no doubt about that. But then they took this epidemiological link as travel to Trivandrum. So that was the issue. But in atypical cases of HFMD, it may be very difficult to differentiate from monkeypox. That is what I have read from literature. Another point which may not be of practical importance is in HFMD, the progression to pustules and all may not be that much. So that is what I read. but in practice it may be different. Yeah.
So maybe the age group, second thing would be the clustering around the elbows, the knees, as well as the gluteal region. Then the evolution of vesicular stage more than before the papillar stage. And then basically the itchy nature, sir. And as you have told, this may be of help, so that's what I feel like, sir.
Okay, thank you, sir.
But
One more
suppose the
thing-
patient is having an epidemiological link, I think it will be very difficult.
Yes, sir. Obviously. Ma'am, actually, another thing that can be confused with is the exaggerated insect bite reaction, ma'am, and exaggerated insect bite reaction and drug rash. Ma'am, any pointers how itchy is actually the issue of itching would come in that particular scenario, ma'am? May I would ask you how about the differentiating points that you could think of?
Lesions, when they start, are supposed to be painful, as described in the literature, and only towards a healing phase or the subsiding phase, they become itchy. So, but unlike that, in the exaggerated insect bite reaction, there'll be pruritic right from the beginning. So I think that should be helpful. Plus, of course, the history of exposure to insect bites and all those things will be helpful just to corroborate the diagnosis.
One practical point with regard to this question, those people who are on has been put on symptom surveillance, like doctors and all. Okay, if they develop some sort of an insect reaction, they will have to go for isolation. That is the issue. We have actually faced that problem. One of our staff developed conjunctivitis, and definitely, has to be isolated. So this is an issue.
Yeah, can I tell something? Dr. Ashokan here.
Sure, sir, please.
Yes.
Okay. No, the thing is that now the cases are few and far in between, and this epidemiological link, especially of coming from a foreign country, is actually helpful to us. But let us pray that it stays that way. If it becomes a little more common in the community or larger number of cases come, the dermatologist is going to have a very tough time. None of these features can be concerned. We have so many dermatological conditions, some of which have already been mentioned, like insect bite reaction with a bullous lesion. And remember, that can even occur in children who come from Gulf. They typically develop a severe insect bite reaction with bullous lesions. So that can be there. HFMD has been correctly been identified as a possible confusing condition. Then herpes simplex already mentioned. And remember, we know that herpes simplex also can have a erythema multiforme, which can have bullous lesions elsewhere on the body. So, and many of these have their own lot of range of variations. So it is, let us pray that it stays this way, that these are only few cases coming from Gulf and remains that way. That is what just a point. In that way, in that sense, what we need to do now is to have that suspicion around, and because it has such a big public health importance, don't take any chance and do investigate. I think that should be the message I think we should have now. Don't take chance on the other side and be on the safer side, and do the whatever screening and the investigations needed to rule out monkeypox at this point of time. And maybe this can change over a period of time. Thank you.
Okay. There are a few more questions by Dr. Nikhil. Is there any international travel guideline?
Actually, international travel guidelines are there. International travel guidelines means that as of now, WHO has not declared it as a pandemic or an infection of international concern. They have not declared it like that. But then the IHR regulations, all those things are in place, and people who are having fever, etc., are not supposed to board flights. So that is there. And definitely both these patients, they landed in Kerala. So even if the regulations are there, the Keralites, because of their very bad COVID experience while in the Middle East, what this patient also told me is that there, no one was taking care of the patients, and so many patients died due to COVID-19. The moment they are thinking that they are infected with something like monkeypox, the first thought is how somehow to reach Kerala so that they can be saved. That is why they are flying in. I actually can't blame them also.
Yes, sir. Question by Dr. Midun Raj. Do you see Yashas in monkeypox cases? Yasha.
Actually, madam, you're saying crust. The crusting is occurring.
Okay, sir. Another question by Dr. Geetanjali. Are asymptomatic cases possible? If yes,
symptomatic cases are possible. Subclinical cases are also possible. So all these things, the recent WHO guideline did mention about asymptomatic cases as well as subclinical cases. And there is one interesting study where now the presentation is as tenesmus, proctitis, etc., has become the presenting features of this thing, monkeypox. And they took sort of a surveillance rectal swab, and they identified out of 146, 3 persons with this swab positivity, rectal swab positivity for monkeypox. They were totally asymptomatic. Okay.
Okay, sir. So can they transmit? That is the second part of the question.
The WHO says that no, you require more data.
Okay. Another
regarding the presence of virus in semen, also they have said that no, we can't say that the presence of viral DNA in semen, you cannot equate it with transmissibility through semen.
Question by Dr. Venukumar. If smallpox vaccination gives protection, now old age ones who got smallpox vaccination, can they be protected? Maybe that is what he meant.
Actually, this is one reason why in the high risk groups, elderly were not included, right? That's because all of them are supposed to have got the smallpox vaccine, and 85% protection is there for smallpox vaccine. And whether smallpox vaccine can be used as a method to bring down the the magnitude of this monkeypox outbreak, it is being used in Europe. It's being used in USA also. They're being used as a pre-exposure prophylaxis, post-exposure prophylaxis. That is within 4 days of contact, up to around say 14 days you can use it. And there have been outbreaks around this, the rave parties, the MSM parties and all. There they are using it as ring vaccination, just like the polio ring vaccination. They are using smallpox ring vaccination, not the first generation vaccine, the second and third generation vaccines.
Okay, sir. So the last question in the chat box: is there any chance of expecting a rapid antigen kit like that for COVID-19 in near future? By Dr. Sri Kumar.
Actually, as of now in Europe also, they have not come out with an antigen test. Probably it should be possible. The NIV is actually collecting the blood samples, and they're going to follow it up for say 6 months or so. And based on this, probably they may come out with a lateral flow assay, ELISA or something like that. As of now, we don't have access to any antigen test.
Okay, sir. So I think if there are no further questions, maybe we can. Mohammed sir.
Yes.
The questions in chat box are over. Yes, sir. So I think we have. Okay. So I think we have come to the end of the session. Wonderful session, an exhaustive session we had on the emerging monkeypox. So thank you all. Thank you, Mohammed sir, President IADVL State, Kerala State, Secretary Dr. Sandeep Lal, our eminent speakers, Dr. Anuja Elizabeth George, and Dr. Aravind, and all the audience who had patient listening as well as active participation in the session. Thank you one and all. Good night.
Thank you.
Thank you.
Thank you.
Thank you very much.